Okay, this is the case for people who did not attend the first session early morning. It's a bifurcation, LAD diagonal, and there was a disease in the mid-LAD very tight. And as I told you, because of the diagonal size, and this is in 2002, I decided to go for two-stent strategy from the beginning. And this is how I did. I dealt with the mid-LAD lesion. Then I went with the double wire. I did angioplasty, balloon angioplasty of the ostial diagonal, as you can see in two views here. And this is a mini crush of the ostial diagonal, and you can see another stent in the LAD. And this is the LAD stenting. This is after some ballooning, which is not included here, is a final result of the LAD diagonal bifurcation, as you can see here. And as I mentioned, this is a patient who see me in the clinic, and he belongs to the hospital. And in 2010, he came in back. That's 8 years after his stent, which was a first-generation drug-eluting stents in 2002. You see the progression of his disease. He came in with unstable angina after 8 years. He had a native disease now in his ramus. He had a tapering of his distal left main, which is not that bad. He had some disease in the circumflex, and he occluded the bifurcation completely. And as you can see here, you don't see the diagonal LAD, it's disappearing, some tapering of the distal left main, and even the stent in the RCA, he had in-stent and in-segment restenosis. We decided to take him to the meeting, to the combined meeting, and we discussed the case thoroughly. And the vote at that time was for bypass surgery because he is 35 now. When we did his primary PCI, he was only 27. And he went for cabbage ×4. And actually, his ejection fraction during the follow-up was 45. When he presented after 8 years with unstable angina with those lesions, as you can see, he dropped his ejection fraction down to 35. Thank you.